Thank you for answering the pretest. Welcome to the online session of umbilical vein catheterization. Hello there. I am Dr. Christine Del Rosario Pajeda, a newborn medicine specialist. Two parts of this topic, the online session and the demo return demo session. At the end of this topic, you should be able to demonstrate proper umbilical cannulation using a mannequin or a task trainer. There are numerous indications for umbilical vein cannulation. These are venous access from early after birth in all very preterm babies and other babies requiring respiratory support. For urgent vascular access in resuscitation for administration of medications or volume expansion, infusion of hypertonic solutions, total parenteral nutrition, and exchange transfusion. But before doing the procedure, one must be ready with the necessary materials. These are sterile gloves and gown, instrument pack, sterile drapes, antiseptic solutions, sterile gauze and or cotton, cord tie, a scalpel blade, umbilical catheter, syringes with sodium chloride 0.9% flush, silk suture, routine IV line and tubing setup, and other tapes. In preparing the infant for the procedure, the infant should be placed on an open heated cot. Restrain the infant's extremities while maintaining measures to keep the infant comfortable and continuous monitoring of vital signs. An appropriate catheter size should also be selected. Multiple lumen catheters are preferred, especially if the infant's birth weight is less than 1,000 grams or extremely sick. A single lumen catheter may be inserted as an option if the catheter is deemed for short-term use or if multiple lumen catheters are unavailable. French 3.5 is preferable for newborns with birth weight of less than 1,500 grams, while French 5 catheters for newborns with birth weight more than or equal 1,500 grams. If both are unavailable or in an emergency, a feeding tube size French 5 may be used. The length of the catheter to be inserted should also be determined prior to the procedure. One may opt either the Dunn method or the Shukla and Ferrara method in determining catheter length insertion. The Dunn method is by measuring in centimeters the perpendicular line dropped from the tip of the shoulder to the level of the umbilicus as seen in the illustration. Plot the measured shoulder to umbilical length using the graph to determine the catheter length to be inserted. For example, if the measured shoulder to umbilical length is 12 centimeters, the catheter length to be inserted should be 8 centimeters. Another method is the Shukla and Ferrara, which is based on the infant's birth weight in kilograms. Catheter length to be inserted is determined by using the formula shown. In emergency situations, the umbilical vein catheter may be inserted between 2 to 4 cm's length. Properly follow the steps in umbilical cannulation. Step 1. Observe proper hand washing, gowning, and gloving. Step 2. Set up equipments while maintaining sterile technique. Step 3. Prime the umbilical catheter using the heparinized saline and leave syringe attached to the catheter. Step 4. Sterilize the cord and area around the cord with antiseptic solution. Step 5. Drape the area around the cord. Step 6. Remove first set of gloves and replace with a new set of sterile gloves. Step 7. Place the sterile cord tie around the base of the cord and tie in a loop with moderate tension. Step 8. Use the scalpel to cut the cord between the cord clamp and the skin at the base of the umbilicus. Cut away from you and close to the clamp. Step 9. Identify the vessels and probe the vein. There are 2 arteries and a single vein. Step 10. Grasp the edge of the cord with a suture forceps and use the lacrimal probe or the fine-tooth forceps to tease open the vein. Step 11. Introduce and advance the catheter. Ease the catheter into the open vein and advance slowly to the estimated insertion distance. Withdraw on the syringe to test whether you can get free-flowing withdrawal of blood. If you can't withdraw blood, it usually means the catheter tip is in the hepatic or portal veins. So withdraw the catheter slowly until you get free flow of blood. You may collect specimen at this stage, then flush catheter gently and make sure that no air bubbles are present.
Step 12. Secure the catheter by anchoring the catheter to the base via purse string method, bridge, or clear tape as depicted in illustrations. Step 13. Locate catheter.
The ideal catheter tip position is at the junction of the ductus venosus and inferior vena cava, which is usually seen at T6 to T9 vertebra. On X-ray, this has the appearance shown with the UVC going straight up with the tip of the level of the diaphragm. A UVC with a tip in a good position can be used for ongoing intravenous needs for up to 14 days. A UVC with a tip in an intermediate or low position should not usually be left in situ for more than 48 to 72 hours unless the clinical situation is critical and there is no alternative secure venous access. Aftercare of umbilical catheterization should include checking that the infant is left clean and dry, linen under the infant is not wet or soiled, and assess temperature and vital signs. Make sure that the catheters are secured before, during, and after X-rays. Check if the ties and sutures are not pressing on the skin. Complete your documentation, and use aseptic technique when managing UVC ports. Observe umbilical area for signs of local or infection or bleeding, blanching of the skin surrounding the umbilicus during infusion of inotrope. Observe color of abdomen and report any abdominal distension or discomfort, edema or color changes of the legs which may indicate a problem with venous return. Complications of umbilical catheterizations are sepsis, bleeding due to disconnection of tubings or loose cord tie at the base of the umbilicus, vessel perforation. One should never cut the rounded tip of the catheter. Clot formation, embolism, spasm. Always make sure that the catheter is patent with no air bubbles. Gentle flushing is recommended to avoid spasms. Catheter malposition effects are cardiac arrhythmias, hepatic necrosis or portal hypertension, cardiac tamponade, and ascites. Contraindications of UVC placement are gastroschisis, omphalitis, omphalocele, peritonitis, and necrotizing enterocolitis.
When the umbilical catheter is to be removed, turn the infusion off prior to pulling it out. If cord is dried up and difficult to remove the suture, soak the cord with wet gauze and leave it for 5 to 10 minutes, but make sure that the baby does not get cold. Observe proper gloving and aseptic technique of the cord. Remove sutures carefully, then slowly withdraw the catheter, making sure that the entire catheter is removed. Send tip for culture if infection is suspected. If bleeding occurs, press firmly above the umbilicus. For umbilical artery catheter removal, place a cord tie in case of bleeding and slowly withdraw the catheter until about 5 centimeters of catheter remaining inside. Tighten the cord tie, then withdraw the remainder very slowly, allowing the vessels to contract. If bleeding occurs, apply lateral pressure to the cord. Leave the abdomen visible post-removal to observe for any bleeding. In summary, we were able to discuss the indications for doing umbilical catheterization, the proper procedural technique, aftercare, complications, and contraindications. These are my references. Kindly answer the post-test. See you for the face-to-face demo and return demo session of this topic. Thank you.